It's my great pleasure now to welcome Magdalena Filipowicz, who is a senior consultant in hepatology and gastroenterology at Kantonsspital Basel-Land. At the same time, research group leader in hepatology at the Department of Biomedicine in the University of Basel. As Darius was saying, the new power generation. And of course, another pillar of Swiss hepatology. And I was lucky enough to be his mentee for, 12, 14 years. Be at Müllhaupt, head of hepatology at the University Hospital in Zurich. And maybe we can wrap this up and get some new insights and a brief discussion about. Starting off maybe with the end point, actually. Given the fact that we are not only hepatologists here, many of us are gastroenterologists or gastroenterologists and hepatologists. Looking into the future, what do you think will be the three most important things to implement in our clinic to prep for hepatology future in our patient care?
This is a question for me, Joachim.
I throw this out there.
I think it's for you, Darius.
The three most important.
If you can send everybody here home with, you should really try to keep these three things in mind when you see the next patient you suspect to have something in the liver.
Yeah, I think alertness and screening in the right situation is important for viral hepatitis, for fatty liver disease, for abusive alcohol consumption, or whatever be it. So I think alertness, screening for certain pathologies will be important, and prevention through promoting a healthy lifestyle. It's easy to say, but very difficult to do. I think these are probably the two most important. Don't know what you think, Magdalena, and what you think, Beat. There's certainly many other things that are very important.
I will catch up on the topic of screening, but this will also go to. So with the increasing burden of obesity and non-alcoholic fatty liver disease, and also despite cure in Hep C and effective treatments in Hep B, there is increasing incidence of hepatocellular carcinoma. The patients even that are cured and had advanced fibrosis from Hep C and Hep B have to stay in the screening programs. So, as you said, there is not that many gastroenterologists and hepatologists. How should we, within the next decade, handle screening of patients for hepatocellular carcinoma?
Yeah, I think this is an issue in our daily practice, and I think we need to build networks. We cannot do the ultrasounds for all pre-cirrhotic or cirrhotic patients, but we need to connect with our colleagues in the different areas that we cover, who work with radiologists, with colleagues in gastroenterology in private practice, to really ensure that those that are at risk have their 6-monthly ultrasound. I think that is really important. At the same time, there's many open issues right now. We know that liver cancer can develop directly from steatohepatitis without going through a stage of cirrhosis. It's rare, fortunately, but it happens, and we see it regularly. So where do we need to introduce a screening program in those patients? I think that there we need much more information, and I very much hope that genetic information, will help us to risk stratify patients, maybe genetics plus some clinical features, diabetes or something else. But I think that we cannot do it alone. We really need to build the networks and to ensure that our patients are properly screened. The only way to have a chance for cure in liver cancer is to be detected early.
Yeah, I agree with you, but I think you mentioned big data, and I think big data will probably help us to understand metabolic liver disease or NASH in a better way. I think we will have subgroups of NASH with different pathway leading to liver steatosis. I'm also convinced that we will have blood-based tests for detecting HCC at an early stage. We cannot rely on ultrasound. I think it will never be enough for this wave that's coming. And an important part, I think, is getting involved into politics. I think food processing has to be changed in Switzerland if we want to change the wave. I mean, you did mention the epidemiology in Switzerland. 16% of children are overweight or obese. And that's a huge wave that's coming, and we can only change this if we change the food processing and the sugar content in our daily food. I mean, as an example, for 150 years ago, we ate 2 sugars per day, and now it's 27 per day. So we need to change this. And at the same time, movement went down. So I think we need to intervene at the very early stage and at the political level.
Is there efforts happening already in this direction?
I mean, our good friend David always tells about the sugar community.
I mean, concrete efforts.
Yeah, I think they reduced sugar a little bit, but it's not enough. And if you compare soft drinks in different countries in Switzerland, Switzerland has one of the highest sugar contents in soft drinks compared to other countries. So I think there's a lot of improvement to be made. Only with this we can get this under control, I'm convinced. It has to happen outside the hospital.
If you look at the coalitions that you can think of to tackle future liver disease, what do you think is the most important within the medical field? What will be the most important? I think primary care physicians is quite clear, GPs. You mentioned endocrinologists. Shouldn't we have a MAFLD society or a MAFLD convention that includes all those? Because so far, I think most of our subspecialties in medicine really do their own thing.
Yeah, but I think that interaction is increasing, and that's the beauty of hepatology. You know, it has a tradition of interacting with so many disciplines, and I think this is in the DNA of hepatology ever since. You know, and this will continue. And yeah, why not an MAFLD summit? I mean, EASL has an MAFLD summit, and these are efforts that go into the good direction. Nutritionists are very much involved. Primary care providers, endocrinologists. The guidelines are common guidelines, you know, of EASL with endocrinologists. Of course, more needs to be done, but I think that the start is there.
I think it depends also a little bit whether you look at early liver disease or late liver disease. I think correlations are different. In early liver disease, certainly general practitioner, endocrinologist, the public is important. End-stage liver disease, I think we need the collaboration with surgeons, interventional radiologists, oncologists. I think it depends a little bit on the position.
Bernard.
We talked a lot about the nutrition. I want to just go back to Star Wars quickly, because you elegantly skirted the issue. You showed Star Wars and all the entry points. I mean, it's not all about medicines, but medicines may help.
Of course.
And it's definitely Mediterranean diet, beautiful, Bella Italia. But, you know, some people will just not wing it. And, you know, the ones that advance to NASH, and NASH is the thing, there's so many entry points. So which ones, in your opinion, of the 300 that's been tested right now, are the most promising ones?
You know, it's difficult to say right now, and I think it's fantastic to have this effort and to have the interest of the pharmaceutical industry in this area. And I really hope that there will be some successes that will keep them in the area, because one risk is to become discouraged and move away to other topics. So right now, I think we have some good drugs that are being used already for the treatment of diabetes. And it's good to use drugs that also have an effect on MAFLD NASH, like, you know, the GLP-1 analogs. I think that we see great successes now with GLP-1 analogs, also on the liver disease, and maybe something like a pioglitazone, you know. So I think these are promising approaches. And there's certainly others in the ones that are currently being evaluated in phase 1, early phase 2, you know. We didn't speak about the whole anti-fibrotic treatments, you know. So it's just to be hoped that more drugs will stand to the endpoints that have been set and be successful. But right now, I think we work closely with our colleagues in endocrinology, for example, for GLP-1 analogs, and for many patients, we see great successes.
Would you, if you had to bet which pathways, you know, the FXRs were like really high and so on. If
you
any,
want to invest or what?
no. I'm just interested in what they think, you know.
I think
I have no money to invest. I have 4 kids.
It's really early, you know, and you know that I'm not a specialist in those pathways. I think it's, you know, and what for me is really amazing is that these pathways are so pleiotropic. You know, if you deal with the nuclear receptor and you see the targets of that nuclear receptor, it's really amazing how courageous companies are going onto these targets. But I think that the only way is to, you know, have a stepwise approach, and I'm sure that several will be successful.
There's 2 more questions.
Staying on the therapeutics of MAFLD, I would like to ask you how keen you are to recommend bariatric endoscopy or bariatric surgery, and for which patients?
Yeah, I didn't speak about bariatric surgery, but it definitely has its very strong place. It's on the one slide that I showed you with the risk-based approach, and it's in all the columns. Yeah. So I think with a proper indication and pre-intervention, you know, evaluation and follow-up post-intervention, I think this is absolutely central today.
Thank you.
I think there are also very promising data with dual integrin antagonists that is recently published in the New England Journal. I mean, 72 weeks, weight loss of 22%. I think that's very encouraging, and we know from dietary studies, we know from bariatric surgery that weight loss can improve NASH, can regress fibrosis. I think weight loss is certainly one of the goals, and if we can achieve this in a higher proportion, even maybe not without surgery, I think that would be a great benefit.
If we just for the last question, zoom in one moment into the viral hepatitis, because we all think everything is well and good, but as we just saw, it's absolutely not the case. So there are still, you know, undetected Hep C patients, obviously, in Switzerland as well, and I think maybe we can, you know, kind of spread the word that still screening for hepatitis C is worth the effort. It remains a problematic disease, and it's one that can be cured very easily. Do we know what the numbers are? Have we a grasp of how many do we miss?
Beat, you've been more involved than I in...
There are always figures out there, but it's always, I think, difficult to predict. I think it was at ASLD, it was very interesting to see that the United States lances a great effort for screening under the auspices of the White House, and it just shows that, I mean, it's different input in other countries. In Switzerland, it's more or less a private initiative that tries to increase screening, and in the US, it comes directly from the White House, and I think we will see how much impact this has. But the US has also a little bit a different problem. I think with the whole opioid crisis, they don't have a dromedar. When we have a dromedar, we have a single peak, and the US now has a second peak coming from the opioid crisis. And this maybe also shows that we need maybe a vaccine to finally control the disease. I think there are very few infectious diseases that are controlled without vaccine. So I think that's still a good investment or a good achievement if you could have a vaccine for hepatitis C.
Are there any further burning questions? If that's not the case, I think we wrap up the session. Thank you all for coming.
Thank you.